Hey everyone, Dr. Eric here from MedBetter Health, where we help caregivers like you taking care of persons living with dementia through our incredible new program with Medicare called the Guide Model. I'll tell you more about that in a second. But today's lesson is so important for you, and the topic of it is advanced care planning. Let me tell you a quick story. I was a resident physician. This was my first year of residency. I think it was maybe even my second year of residency. And I am the doctor in the intensive care unit. I want you to picture a lot of bells, doom, 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 a lot of nurses, doctors running around. And I remember I was the doctor there, right? And intensive care means everyone is pretty sick, intensive care. And I remember I was sitting in one of the rooms, I was taking care of a patient, and there was an elderly man. And the elderly man, I want to paint the picture. You come into the room, you see that he is intubated. You see that he has all these tubes inside. He has a catheter. He has all these different central lines all over, right? And he's laying there and he's not conscious, and the machines are beeping, and there's a machine, the ventilator, that's keeping him alive through the air by giving him air. And I see his wife and his daughter sitting there. And the daughter asks the mom a question, and she says, "Mom, I'd like to ask you a question. Is this what Dad wanted?" Think about that. Is this what Dad wanted? Did he want to lay in bed like this when he was very, very sick, and he was resuscitated because his heart stopped, and someone came in and did something called CPR, right? Cardiopulmonary resuscitation. And they started, as you see in the movie, press down on his heart, right? And then when he couldn't breathe, someone came in and put a tube inside his mouth so that you can have aeration for him and air to come in through the ventilator. And the daughter was asking, is that what Dad would have wanted? And the mom looks at the daughter and she says, "Honey, you know, Dad and I spoke about this, and he told me actually that he doesn't want that. He just wanted to go very easy. But the problem is, honey, I wasn't home. The home health aide was home. She was taking care of him. We didn't have any plans. We didn't have anything documented. We didn't have anything written. We didn't have any doctor orders. And when the EMS, Emergency Medical Services, when they came in, what did they do? They saw a lifeless body. He didn't have a pulse. They started to resuscitate him. They got a pulse back. They intubated him. By the time I came to the hospital, it was too late. And like, this is where we're at now. And I remember as a resident, like, that hit me hard. I'm like, man, I see this gentleman, he's laying in bed. He's completely, something called anasarca, where you have swelling and edema of your whole body because you're laying there. Now, I'm not saying that intubation or resuscitation is a bad thing. Don't take it the wrong way. And I'm not saying that to do or not to do. It's a personal preference. There are no right or wrong answers. This is something that you discuss with your family. This is something you discuss with your priest, with your rabbi, with your imam. This is something it's a discussion. There's no right or wrong. But once you made that decision, you'd wish that in the end of your life, that decision is respected. So why is it that today so many people end up in the same story like I've described to you today? And why am I here in front of you? Well, I made it my mission to ensure that that doesn't happen, that we have a conversation with caregivers, with persons living with dementia, with anybody about something called goals of care. And in fact, I want to tell you, it's a very difficult conversation to have. But as I always say, it's better to have difficult conversations than to be in difficult situations. And here in the Guide Model, which stands for Guiding an Improved Dementia Experience, which is a new Medicare program, we help caregivers like you go through these conversations early on. And if you're interested in learning more about the Guide Model, which can help caregivers like you get additional resources like home care at no cost through Medicare, I want you to look up over here. There's a link. I want you to visit this link. You can also scan the QR code and you can see the link in the description. But before I move on, I want to focus on goals of care a little more. So are you ready to take this journey? This will be one of the most important videos that you watch out there in the virtual world. Come with me along the ride. So let's take a look. Well, first of all, let's look at something interesting, the statistic. I want you to look at this number, 19.6%. So almost 20%. 20% what? Well, in the final 6 months of life, individuals with dementia spend an average of 20% of their life hospitalized. And if you want to translate that to weeks, that's nearly 1 week out of every month in the hospital bed. 1 week out of every month. Interesting, huh? Well, let's take a look at some more statistics. Well, 70% of people at the end of their life lack the capacity to communicate their preferences due to advanced dementia. That means if mom or dad has advanced dementia, and when mom and dad had mild or moderate dementia, you didn't really have an opportunity to talk to them about end of life, about resuscitation, about healthcare proxy, all that stuff, they won't have the capacity to make that decision. And then what happens? Who does that decision fall on? I'm looking at you, the caregiver. Now, do you think that's an easy decision to make for you? And if you're alone, that's okay. If you're the only child like I am, it's a little easier, right? Because I'm the only one who's going to make the decision. But what if you have siblings? And what if one sibling says, nah, mom would have wanted this to happen? And the other sibling says, no, mom said she wanted that to happen. And mom is part of that 70% that does not have the capacity to communicate her decision. What is happening between the family members towards the end of life? And you don't want that. So it's better to have difficult conversations than to be in difficult situations. Let's continue. What it is. What is a healthcare proxy? That's the foundation. What's a healthcare proxy? It's a legal designation of a trusted decision maker when capacity is lost. So mom, when she has a little bit of mild cognitive impairment or mild dementia, she says, I got 4 boys, 1 girl. I want to designate my daughter or my son as my healthcare proxy to make decisions on my behalf. That's a legal designation. So when you go to the hospital and there's 3, 4 people there, the doctor will say, let me ask you a question. Who is the healthcare proxy making these decisions on behalf of mom who no longer has the capacity to make that decision? What's the risk of default? And this is so important. Without a proxy, no proxy, right? Here you go. Hospitals default to state family hierarchies, right? So whether it's the wife, then the kids, but it leads to decisions by providers or distant relatives who don't really know the values of the patient, who don't know the values. So that's very important for you. And family surrogates who are formally prepared report significantly lower decisional conflict and caregiver distress. So important for you to know this. And I hope you're finding this helpful. And by the way, if you remember when I talked about the guide model, this is exactly what we do. You get your own care navigator. You get your own dementia proficient provider who sits with you, who goes through this with you, who plans with you, who finds out what resources are you missing. So again, if you're interested in learning more about the guide model, I want you to look up on your screen. You're going to see a link. Go to that link. Make sure to apply. It will change your life. You won't be in a difficult situation because we'll help you through that difficult conversation. Okay, now let's take a look. Living wills versus a MOLST, POLST, or DNR. If you're hearing these terms for the first time, it's okay. I'm here for you. So, what is the living will? The living will is a legal guidance and its values, right? It's the values of what we want to be done. Need for interpretation. There's very often a high need to interpret it. That's why the lawyers put it together to try to make it as specific and not vague as possible. Is it honored by EMTs during a crisis? Here's an example. Remember that example I gave you in the beginning, that story of the gentleman? If the gentleman would be on the floor and the wife would tell the EMTs, I have a living will, a lot of EMTs may not legally stop resuscitation if it's just a living will, right? It won't work. So you could say, I have a living will. Yeah, we've planned everything out. No, we haven't yet, right? And flexibility. Static, it's hypothetical. What about orders? Now that's where it comes. There's something called the POLST. In some states it's called the MOLST. And then the DNR, do not resuscitate. So as you're looking at this, right, it's a binding medical order. It says straight out what needs to happen if your loved one is in a specific situation when it comes to resuscitation, when it comes to intubation, right? There's no need to interpret it. And it's immediately binding for first responders. That's why when you have that document called the Do Not Resuscitate document, and it's different in every state, right? The MOLST, the POST. Imagine mom is at home and you, the daughter, live in your apartment. And you take this POST form or MOLST or DNR and you keep it in your apartment. And mom's at home, she has a caregiver, and something happens to mom and the EMS comes and they're looking for the form. Where is the form? Oh, it's in your home? Can they actually get a copy of it at that time? No. So make sure that if you do have the DNR, if you do have it, that you actually have it in the home of the person, and the loved ones who are there know exactly where it's located. Now again, I'm not saying everyone should have a DNR, do not resuscitate. As I mentioned in the beginning, there's no right or wrong. It's a personal preference. But once you do have it, that document needs to live in the same area, in the same building, in the same place as the person who it's written for. Very, very important. So a living will provides the map, but in a medical emergency, first responders only have time to follow orders, and they're going to ask you for those forms, for that DNR. Okay. Now, what is a POLST? What is a MOLST, right? It has a couple of things here. Number one, resuscitation. There's full CPR versus do not resuscitate. Full CPR is, hey, I want you to do the compression. I want you to do the resuscitation. Do not resuscitate means do not resuscitate. Do not press on the chest, right? Then it says ventilation, intubation versus non-invasive support. Intubation is putting in a tube when someone can't breathe. That's also in a post-MOLST form. What else is there? This is very, very important. Feeding tube insertion. In the time that my mom won't be able to eat because of her progressive dementia, are we going to look at her and say, well, that's the natural progression, we're going to let her go? Or are we going to say, no, we're going to put in a feeding tube because we want to give her nutrition? Again, I don't want to tell you what to do. You'll ask your medical professional, right? These are very deep conversations, but I want you to be aware of these things because it's not, a lot of the times it's not if it's going to happen, but it's when it's going to happen. You want to be prepared. So here's another one, hospitalization it talks about. Do you want to get full support or treatment in place, right? Do you want to go to the hospital or do you just want to be treated in your home if it comes to that towards the end? So it's very, very important that you actually have these things in place. Now, this is very, very important. System integration, the hierarchy of the documents. I want you to know the authority. Who decides? The healthcare proxy will make the decisions. So in your family, for your mom, for your dad, for your loved one, you want to know who is legally designated as the healthcare proxy. Number two, the philosophy. When mom still has mild cognitive impairment or a little bit of a mild dementia, that's where the living will have these goals. It will talk about what her philosophy is. But it's, when an EMS comes, again, living will isn't used. The DNR, the POLST, or the MOLST is used. Translation, right? What are the orders? That's what I talked about right here. The POLST, MOLST, or DNR, DNI. So this is very, very, very important. And the last slide, that I want to tell you, and we go through this a lot with families, and family members tell us, you know, we're so thankful that Med Better Health is participating in this program called the Guide Model. Because when we go to our doctor's office, it's not that we have a bad doctor, but they're busy. They got 30, 40 patients in the waiting room. They've got 15 minutes to spend with us. But Med Better Health sits down and goes in detail and explains this and helps navigate for the family member when it comes to these decisions, among so many other things. And again, if you really want to find out what the guide model is about, because this video isn't about that, I just want to educate you here. But I implore you to go to this website over here that you see on your screen, and I want you to go and really learn about how we can help you. And remember, that's just vision. I want you to take action. I want you to apply, and I want you to apply so you can get the benefit of it. Let's finish up by demystifying end-of-life care, fact versus fiction. This should probably be a short on its own because it's so important. So let's demystify this. Towards the end of life, right? DNR. DNR means, that's the myth, means do not treat. If I'm going to tell my mom DNR, or I'm going to write DNR, doctors are not going to treat her. That's actually a myth. That's not true. What DNR really means is no CPR, right? No resuscitation, no cardiopulmonary resuscitation like you see in the movies. Full comfort care. It means we're going to give pain meds, and we're going to give symptom treatment to continue. If someone has a UTI, if someone has a pneumonia, that doesn't mean that we're not going to treat. We're going to continue to treat. That's for a fact, right? We're just not going to resuscitate, press on the chest, or intubate in a DNR, DNI. Another one. This is a real important one. Feeding tubes prolong life in advanced dementia. It's a very difficult conversation. You're looking at mom. Mom's not eating. My grandma's going through this right now. She's 93 years old. My mom and dad are 70. They're taking care of my grandma. They're caregivers, just like you. And the guide model is helping them, really helped them a lot. And my grandma's not eating now. And so the question is, well, do we put in a feeding tube? Because how can you, as a son or daughter, you're looking at mom, she's not eating, and it hurts you. You're like, but I have to do something. So you think, well, what if I put a feeding tube and we give her the food through the tube inside her stomach? She'll live longer. So that kind of makes logical sense, but let's look at the data. Clinical consensus confirms that feeding tubes do not prolong life. They do not prevent pneumonia. Actually, very often they can cause aspiration pneumonia, or they do not improve comfort in advanced stages of dementia. That's important for you to know when you're making that decision. Again, I'm not telling you what to do. That's a discussion with your healthcare provider, but I want to empower and educate you. Myth: without planning, the system defaults to comfort. Oh, well, they're going to go to the hospital, they're going to see that mom is already elderly, and they're not going to do anything, they're going to do comfort. No, that's not how the healthcare system works. Just the opposite. The medical system legally defaults to aggressive maximal interventions unless it's ordered otherwise. Think about that doctor. He's going to be like, oh, I'm not going to treat, and then the family's going to say, you didn't treat my mom? Oh, they're going to sue me. I got to do everything I can unless I have orders from the family exactly what they want, right? Super important for you to know that. That's the psychology of the medical healthcare system. Now, myth: it's depressing. We should wait to have that difficult conversation. Let's just wait. Let's just put it off. I know. I get it. I've been there many times, both personally and professionally. However, the reality is early planning drastically reduces crisis decision-making, leading to measurable relief and peace of mind for the families. Like I always say, it's better to have difficult conversations than to be in, you've heard me say it before, in difficult conversations. Look, if you like this video and you found value from it, I want you to subscribe. I want you to like. I want you to comment below what you feel. Subscribing and liking allows us to share this information through the algorithms with so many other people that you can help just like you. The other thing is, if you're a caregiver, I want you to know you're not alone. You're not alone. There are so many resources. Imagine having a resource like me, a Dr. Eric, or a care navigator that holds your hand. Imagine a world where at 10 o'clock at night, if something is wrong, you can call somebody who understands the dementia and can actually walk you through it, and it's a social worker or an RN or a medical professional. Well, with our guide model, you are able to do that. You don't have to imagine anymore. And imagine a world where you're so exhausted. You just went from the hospitalization. Mom was hospitalized. She came home and you're like, I need help after the hospital. I can't handle this alone. Imagine if through the guide model, if you qualify, a private duty home care agency for free at no cost could be in your home for those 5 days, 8 hours a day, 40 hours for that week, taking care of mom, helping you get the relief you want. I don't want you to imagine that anymore. What I want you to do is I want you to look up on your screen. You're going to see a link with a website. I want you to go there. You'll see a video talking about what the guide model is. You'll see a small application. I want you to put in your information there. Once you click that submit button and we get it, we're going to reach out to you, hold your hand, and walk you through things like this. I hope you found this useful. I'll see you in the next video.